So now we have next Dr. Lekha T. She's a senior consultant in retina at Giridhara Institute, Kochi, and she will be speaking to us on central serous retinopathy mimickers.
Thank you, Dr. Nina and Scientific Committee of KSOS. Central serous retinopathy, or CSR, is a very common condition that we see in our clinical practice. Usually seen in the age group of 20 to 50 years, they come with complaints of central scotoma or metamorphopsia. Fundus examination reveals pocket of fluid, and OCT confirms the fluid. Apart from that, might show a pigment epithelial detachment and features of pachychoroid. Depending on the chronicity, it can be acute or chronic. So this is a 46-year-old lady with blurred vision since 1 month. She had similar complaints earlier. Fundus examination showed SRF over the macula, and which was confirmed on OCT. You can also notice a small double layer sign. And fundus fluorescent angiography showed small 2 pinpoint leaks, which progressively increased in the subsequent phases, showing a typical ink blot and a smokestack leak, confirming our diagnosis of acute recurrent CSR. So as we have been already hearing in the previous talks, multimodal imaging is very useful to come to a proper diagnosis, for classification, for planning our treatment, as well as in the follow-up. We have a 45-year-old male here who's a known case of CSR in the past. He came with a recent decrease in vision, and you can see there was some amount of fluid with significant RPE changes, more in the right eye than in the left eye. OCT, it is more of a shallow detachment with more widespread RPE changes, which can be made out on FFA also. Along with that, there were leaks which were seen in both eyes. So these are the features when you see when the disease has become chronic, because the fluid has lasted for longer than 6 months. And these are some of the SD-OCT biomarkers which will help you to diagnose a case of CSR and differentiate it from other conditions. But why is it that we are so concerned about the fluid in the macula? Normally, the healthy retina is maintained in a dehydrated, transparent state so that it is compatible with light transmission. And this subretinal space is just a potential space. It actually does not exist. And this dryness is ensured by a homeostasis between the fluid entry and the fluid exit. When any pathology disrupts this, then only fluid will accumulate, enlarging the subretinal space. And this can occur due to various reasons that causes an increased inflow, such as anything to do with the vascular permeability of the retinal or the choroidal vessels, or abnormal vessels as a neovascularization, or increase in the permeability of the blood retinal barriers. And similarly, anything which interferes with the outflow, that is either with the RPE pump or the molar cells, we can have an exudation in the macular area. So very often we see different diseases which may be diagnosed as CSR. We also see CSR which is referred with a different diagnosis. We'll see more example and learn how to differentiate it. So I'm showing 2 cases, both with fluid in the macula and both with yellow lesions. The one on the left side on OCT showed fluid, subretinal hyperreflective material and a vacuole sign. FFA showed the classical ink blot type of leak. OCTA did not show any network suggestive of CSR with fibrin. On the right side, little more elderly patient, you can see subretinal hyperreflective material, PED. There was a small lazy network which shows increased hyperfluorescence both on FFA and ICGA, definite network on ECTA showing that this is an AMD with CNVM. And this differentiation is important because the first case responded to laser, whereas the second case required anti-VEGF therapy. Very often we see that CNVM can exist in both CSR and AMD. Whenever you are seeing an elderly patient, other features of AMD, definitely try to rule out features of CNVM before labeling it as CSR. And again, emphasizing on the point that multimodal imaging is very useful. One more case of subretinal fluid with an yellowish lesion in an elderly man who is on treatment for CSR. But on OCT, you can see apart from the fluid, there is a typical hyperreflective double layer sign, thumb-like PED, sub-RP hyperreflective material and pachychoroid, hotspot on ICGA, definite network on the OCTA, giving us a diagnosis of polypoidal choroidal vasculopathy, and he did well with anti-VEGF therapy. And these 2 conditions being 2 ends of the same spectrum, they can coexist. And here it is a leakage from the neovascular complex that is the reason for the exudation. So our aim is to treat it either with anti-VEGF or PDT if available. We'll go on to the next set of cases. Here, a young man with sudden decrease in vision since 1 day. Anterior segment was quiet, but fundus showed multiple pockets of fluid, which can be very easily confused with CSR. OCT showed significant SRF as multiple pockets along with subretinal septa, fibrin, bacillary layer detachment. There were few hyperreflective echoes in the vitreous as well. And FFA showed multiple leaks, which you can see are more leaky and more numerous than what you see would in a CSR's case, giving a typical starry sky appearance. ICGA also showed hypofluorescent dark dots, giving us a diagnosis of weak age disease. And this is the most common inflammatory condition mimicking CSR, and it is very important because here steroid is the mainstay of treatment, whereas steroids are absolutely contraindicated in CSR. And here it is the inflammation that is leading to the leakage of fluid. That is why steroids help, and this patient did well with treatment. We have a 35-year-old lady with complaints of pain. I am insisting on the point: pain, redness and swelling with a counting finger vision, anterior uveitis, disc edema, choroidal folds, subretinal fluid, demonstrated very well on OCT. You can see the RP undulations, RNFL edema. With all this, we suspected posterior scleritis, which was confirmed by the T sign on ultrasonography. And this was further supported by the FFA showing the disc leak as well as a pinpoint hyperfluorescence. Here again, it is a scleral inflammation and the associated vasculitis, which is the reason for the exudation in the macula, and definitely steroid is a treatment. And this patient also did well with good resolution of the macular edema as well as a disc edema. This is a 55-year-old lady with defective vision for many years with a vision of 612 and 615. You can see apart from a little fluid in the macular area, there was yellowish lesion bilateral which was hyper-autofluorescent, and the OCT showed this fluid which can be confused with the CSR. But if you look at the line scan through the lesion, you can see hyperreflective material, making us suspect of a Best vitelliform dystrophy. ERG was normal, but EOG showed a reduced Ardens ratio, confirming the diagnosis. And here it is an ionic imbalance in the RPU milieu that leads to the accumulation of the fluid and the vitelliform material. And this patient is remaining stable for years. So this is a situation where you just need to observe and you don't need to make another diagnosis and do any treatment. We have a 19-year-old boy who is on treatment for CSR, counting finger 3-meter vision, and you can see significant fluid in the macular area. But the line scan through the disc gave us a diagnosis of optic disc pit maculopathy, which is due to a congenital abnormality. And here again, the treatment is observation most of the time. One clue is if you see SRF with intraretinal fluid, then that is one feature of optic disc maculopathy, because here the fluid actually enters within the retina, then an outer retinal hole develops, and then the fluid comes into the subretinal space. Another anatomical variation that you can see is the dome-shaped maculopathy, which can present with features of chronic CSR, but a vertical scan through the macula will cleanse the diagnosis. Here is a patient who is on treatment for carcinoma lung, presented with a yellowish lesion with significant SRF, lumpy bumpy appearance on the choroid, giving us a diagnosis of metastasis. Here it was relatively easy because the patient was already on treatment for malignancy. We don't have to do any interference because systemic therapy itself gave complete resolution of the fluid. And remember, this is the most common intraocular malignancy, so we might come across these situations. This is an yellowish lesion with again fluid in the macula. OCT showed several horizontal lamellae. I'm sorry, I'll just take one more minute. And ultrasound shows a hyperechoic lesion with shadowing, suggestive of pseudo-optic nerve. And here we are dealing with osteoma. This is again another patient with significant fluid in the macular area. Detailed evaluation showed an orangish lesion above the disc, which was intensely leaky on angiography, giving the diagnosis of hemangioma, and this patient did well with PDT. This is my last case. He's a 10-year-old boy, came with redness and pain, was diagnosed as anterior uveitis on topical steroids, 660 vision. When we examined, the uveitis was resolving. There was suspicion of very shallow fluid clinically as well as on the OCT. And FFA or ultrasound did not contribute much. We were not sure of the diagnosis. We considered the possibilities of unilateral BKH or posterior scleritis or even masquerade. We started on steroids. 4 days later, vision dropped further. Anterior uveitis was not significant, but there was significant increase in the SRF, which you can make out very well on the OCT. We shifted our treatment to IVMP, still no response. Uveitic, masquerade workup, everything was negative. By that time, the child had to go back to his own place, and he then later went on to another hospital. There they did an examination under anesthesia, and they diagnosed it as rhegmatogenous RD, and the patient was operated. So not all serous macular detachments are CSR. It can be due to a range of conditions from vascular, inflammations, dystrophies, anatomic abnormalities, tumors, and even rhegmatogenous RD. So you should suspect when you don't have any risk factor, non-resolving fluid and not responding to treatment. And I would also stress on the detailed history, thorough evaluation and multimodal imaging, because a correct diagnosis can only ensure a correct treatment. And it's very important that we are aware of these possibilities, because the eyes will not see what the mind does not know. Thank you. Sorry for taking that extra minute.
Yeah, thank you, Dr. Lekha, for that wonderful, case series. And she's clearly explained to us when to suspect a CSR mimicker and what are the clear signs of CSR on OCT. Thank you very much. So, Dr. Marian is going to take a few minutes before she comes with her presentation. So, if you have any doubts, you can take questions. We discussed mimickers and masquerades in glaucoma, amblyopia, optic neuritis, CSR and uveitis. So if you have any doubts, please feel free to ask questions. I have a question. What is this bacillary detachment? That's a new term.
It is a split in subretinal fluid. The fluid is between the neuroretina and the RPE, that we all know. When there is a split within the myoid zone in the photoreceptors, that is within the photoreceptor layer, pocket of fluid occurs. That is called as a bacillary detachment. And it is like you observe in CSR, in inflammatory conditions like VKH, like there are a lot of conditions which can cause bacillary detachment. You will see a layer above the RPE in the outer boundary. So it is within the photoreceptor layer.
That's very characteristic of...
any condition with an acute presentation, whether it is inflammation or CSR, all these you can get.